Welcome, everyone, to Care Model Redesign, Behavioral Health, Why and How. We've got our moderators here. We'll do some short intros. I'm co-moderator, and real quick, I'm going to remind you to use the app, silence your phones, but also use the conference app to kind of access and see the sessions, see the info. And we don't have any polls that are planned, but we will encourage you to read the bios of the moderators and the speakers, because we will stick to, as Kathy mentioned, the no bio rule or short bio rule, because we'll kind of jump right into the content. With this, I'll hand it over to my other co-moderator, Jay Ostrowski.
Thank you, guys. I'm Jay Ostrowski. Is this on? Yeah. So I'm Jay Ostrowski, and I'm a co-moderator as well, and I'm happy that you guys are here. This is going to be a really interesting discussion, I think. So we were thinking about setting this up in the beginning, and like, what do we want to say about Care Model Redesign? And it really struck us hard. Thank you. It really struck us hard that we've had behavioral health treatment for decades, and really haven't thought creatively as a society, at least, about how are we treating people? Should we treat them this way anymore? A lot of us have been stuck in this 1 hour mindset where we bill hourly for a service, and we have all these neat tools for technology, apps and different software, video. We have different new paradigms that are coming out in the treatment space. So we thought it'd be good to get some thought leaders, some people that are doing this together to discuss what's new and what's challenging. How do we go about redesigning our behavioral health care? And it's the beginning of a discussion. There's a lot more to be done, but these guys have done some of that already. And I thought it'd be great to have them here together. So today with us, we have a couple moderators here and one online. So we have Brian Arkwright, who's the founder and chief research officer of Comfort Health. He's done a lot with Wake Forest and setting up multiple telehealth systems. We have Nzinga Harrison online. Dr. Harrison is the chief medical officer and co-founder of Eleanor Health. And then we have Steve Jensen, who's the finance and growth manager of Aspire 365. He'll talk a bit more about what they do as well. And then we have Dr. Kafarian, who's the CEO of Orbit Health Telepsychiatry. So guys, I want to, thank you for being here. This is a challenging project, a challenging time, as you know, and challenging idea of redesigning it. I want to stay away from the organizational change management stuff, because that's just kind of inevitable and known. But in terms of changing behavioral health care paradigm, and what have you guys been doing to take that? Do you want to start us off, Steve?
Sure. Yeah. Can you guys hear me? Is that coming through? Do I need to get closer? Okay. Oh, that feels awkward. So yeah, in dealing with mental health and behavioral health, it's kind of interesting. We started developing programs and systems to start delivering services to people where they are. What we found is that over research and study of looking at the industry, especially as it deals with substance use disorder, which is what we primarily focus on, is that the vast majority of people get no services at all because they're unwilling to leave their world or the life that they have created to go and get services, because typical traditional services take you away from your home or your environment, and they remove you and take you somewhere else. And the other model is that most people in this country are living in areas that are completely underserved, and they have no services at all, especially when it comes to behavioral health. And so it was developing a model where we could get services to people where they are. And so COVID is interesting because we were already in full development of the model and our systems, and then COVID hit, and it forced some of these things to happen. It forced people to start delivering services into the home. It forced people to start changing the way that services are used and delivered and modeled, and it kind of fit in with what we were doing in taking services to the home. And so we started taking psychiatric and therapy services and nursing services to people's homes via virtually and in person as COVID was hitting. And then it just expanded because everybody started doing it. And it's really been good. The one thing that we've seen that's been good is that patients have become very used to receiving services via telehealth now. Whereas even like 3 years ago, I think we could say that most patients just weren't. They just weren't comfortable with it. They'd never tried it. It wasn't something that they were used to, and then they got forced to do it. We also noticed on the other side with physicians, and obviously, Ed, I'll let you speak to this because you are a physician, and therapists. Very few therapists that we knew and had worked with had done very little work in telehealth, and now all of a sudden it's all they do. In fact, guys, half the therapists we work with gave up their offices. They don't even have their offices anymore because they've become so accustomed to delivering services like this. And I think that's very positive. I have a few other ideas of things that we can do as an industry that will help alleviate some of the issues with, needing more services, because we do have a shortage of services in psychiatric as well as therapy services. And I think there's ways we can help fix that. And I think now's the time to do it.
Yeah, Steve, and we want this to be a conversation, and I wanted to ask Steve, so how long have you been in telehealth?
So we started delivering services. The company's been around for 3.5 years, and we started delivering services over a year ago.
Okay.
Actual services in the home.
How many of you in the audience here physically have been in telehealth for more than 5 years? So maybe half. Yeah. And how about everybody who served telehealth services prior to the pandemic, which is most, right? 2/3 at least.
Awesome.
So, and some of us, like I've been in it since 2009, and I think that it's I want to dovetail what you said, Steve, about now almost all the behavioral health services are being done virtually, and prior to the pandemic, almost nobody did it, right? Like a small percentage. And I remember. So being involved in telehealth for so long, I remember the earlier days where we were getting together, in these kind of organizations, the American Telemedicine Association and Mid-Atlantic. And it was almost like the computers, computer technology in the 1980s, where everybody's excited about it. It's not really yet mainstream. The internet's not even really in existence, and everyone knows what's going to happen in the future, and we can't wait. So that future is now. Mm-hmm. And so now this conversation is about what we do moving forward. Now that everybody, the adoption of technology curve, where now the late majority is finally coming to the game, they're forced to from the pandemic. Now we want to talk about telehealth 2.0 that involves everybody. Right.
Yeah. And to add to that, one thing that's been interesting, we were just talking about is, these rural communities, how they've started to adopt telehealth, where they were at a 0%. Come on, 2 years ago, they were at a 0%. They were in rural communities. And especially when it comes to behavioral health. And there are no behavioral health services in these rural communities. And now all of a sudden we can deliver services, and they're accepting those services. And we've been working in rural communities under a federal grant for the last year, a little over a year and a half, and we're getting really good adoption now. And we're actually getting really good engagement, which is, we weren't sure how the engagement would be with psychiatrists who are coming from, out of their rural communities, and therapists that are coming from, but they're visiting via telehealth. And the adoption has been really positive, and the interaction has been really positive, and we're seeing a good results there.
So Ed, do you want to tell a little bit about what you do in your space?
Oh, sure. So I developed the state of California prison system's telepsychiatry program. That's kind of how I got into the game. And like I said, that was around 2009, where I went to headquarters and say, look, we can't hire people in these rural areas. I can hire them in the Bay Area and LA. So let me build that program. And so they surprisingly said yes, where they usually said no. I don't know, it was an act of God or something.
It was, yeah.
So working with bureaucratic systems. And then, so I had some success. We had success. I mean, I didn't do it by myself. A lot of great people working with me. And I figured, well, if this can be done within a government bureaucracy, then it can be done privately. And so I started Orbit Health. And initially it was to serve correctional populations. But then, as we were talking about, the community mental health needs have been soaring. I mean, we probably should talk about that too, right?
Yes.
Yeah. So let's check in with Dr. Harrison online. Dr. Harrison, do you want to unmute and tell us a little bit about the work you're doing and how do you think we should redesign our care?
Yeah, sure. Very similar to what Steve and Ed have already started to say, but Dr. Nzinga Harrison, Chief Medical Officer and co-founder of Eleanor Health. We take care of people who are affected by substance use disorders, practicing during active use, as well as periods of abstinence and relapse, with a whole health model that really takes into account co-occurring mental health needs with the substance use disorder, as well as nurse care management for comorbid physical health needs, as well as health coaching and care navigation and peer coaching for social drivers of health. And so I think similarly to what Steve and Edward were saying, really being able to meet people where they are, what we learned from the pandemic. So we started the company in May of 2019, started seeing, we call our folks community members because we're building community in North Carolina in September of 2019 and are now in 6 different states. And so we built ourselves to be multimodal from the beginning, which is being able to see people virtually, being able to have people come to the clinic, as well as sending our community recovery partners and peers into the community to take care of people so that you could literally meet folks where they are. And what we learned in the pandemic is that, like in-person behavioral health care, virtual behavioral health care really has to focus more on than just the behavioral system. It has to be the entire person. And so COVID wrapped a lot of stress and despair around people, to Ed's recent comment about behavioral health needs becoming more acute and more prevalent. George Floyd wrapped a lot of distress around folks. And we found that for our staff, as well as our community members, like, we had to create increased ways to connect virtually that allowed people to bring their whole selves to the process. And so in talking to our community members, what we really found was that, I think it was Steve that opened up and said, sometimes people can't come in the clinic because of other life demands and priorities, is, overwhelmingly our community members want a mixed course of care. So sometimes they want to see their therapist in person, sometimes they want to see virtually, sometimes they want to come in the clinic. And that varies by resources and access and current needs. And so how do we design a system that can be responsive in the moment to what service that person needs by what modalities, where we've been spending a lot of our time at Eleanor.
That's a big challenge. That's a lot of good work. Bringing the whole person at the point of need, multimodal. It sounds like you did a lot of culture work as well to address culture issues that are really, really important.
That's right.
I think one thing to point out in this discussion, just to really kind of heighten the need of it, if you're not that aware, thing that I've been telling people in other webinars and seminars I've been doing is, we know there's a shortage of providers, but I don't know how many people have embraced the idea, the realization that we will never, ever have enough providers. We will never have enough providers. We grow people faster than we can grow graduate students. And so this is not just a US problem, it's a world problem. And as I work with partners in other countries and do other trainings there, their solution is to poach American doctors and American therapists. So the shortage that we have now is scheduled to be worse than it is now. So we have to be really creative about what we're doing. So in our organization, we're developing new tools to stratify care, to do triage, to how do you help people self-sort themselves without as much labor to get to the right level of care at the right time and the right modality. So we each of us on the panel have different approaches to this. Brian, you want to talk about some of the work that you've done?
Sure thing. I've been involved with telehealth since 2006, and definitely second Edward's comments of, it was challenging back then. Now I think others have maybe seen the light in these telehealth circles. We've always talked of next year will be the big year, when things happen. Well, it came. I don't think any of us expected it.
We told you so, world. You should have listened to us 10 years ago.
We didn't think we'd get hit with a tidal wave like we did, but boy, did it come. I think, some exciting things that I've been involved with is the North Carolina statewide telepsychiatry program. It began as a grant funded program with the Duke Endowment. North Carolina Medicaid has become very involved with it. It became was baked into the kind of policies of North Carolina, where it's remained to this day. So that was around 2013, and that program still exists. I know there's some leadership, I believe, from that program today. And that's something that I think that, we look at the why and the how and the redesign, and those are we need big kind of statewide governments to get involved. We need policy at the state level. And the NC STEP program is something that I believe today it connects to over 55 different counties to, those rural communities that have zero behavioral health access. And oftentimes it's connecting to the emergency department where care is needed most, sometimes in crisis. So I think that I know that's something exciting that Edward and I were talking about. What is needed for the future? How can we get other states to act, other states to put things in policy, other states to be bold. I think that what the conference is, what's your risk tolerance? So you want to add? Go for it.
No, I wanted to jump in and ask Steve, do you want to talk about the design aspect, the actual workflow of treatment in your center?
Yeah, absolutely. I'll take a minute. So we deal in the substance use disorder category. We work with people who have issues with drug and alcohol and need treatment, and we deliver services via a team into their home that includes an addiction psychiatrist, an individual therapist, a family therapist, a nurse, a case manager, and peer support. And we deliver those services. It is mostly via telehealth, some in-person visits as needed, but we've also proven our model in rural communities where it can be 100% telehealth if needed. In those cases, we even do the nursing and drug testing via telehealth, and we've developed a system that does it, and it's been very effective. Like when our team first came up with the idea, I didn't make sense to me, but we implemented it and it works very well. The key component in changing the industry is getting the payers on board. I mean, because we have to all recognize who the clients are, and they are the federal payers, the state payers, and the commercial payers. Those are the clients because they have all the money and they have all the payers. I mean, they have all the clients. And so what we found has been very interesting. In fact, anecdotally, I'll tell you that we were in a meeting with and I don't think they would mind me saying this, with the chief medical team for Humana Healthcare on a national level. And we were with their whole medical team, and we've met with them a few times. And in one of our first meetings, we were talking about taking this model to the home to be able to treat more people and serve more people, because people have to be able to live and work and do their family stuff. And that's why most people don't seek services. And interestingly enough, they said that in their business model, they believe that more and more healthcare, both behavioral health and regular healthcare, is going to be driven back into the home. And that's their model. That is their model going forward in the future. And they told us this about 1.5 years or 2 years ago. And we've since had a lot of follow-up with them. And we're working on contracts right now with Humana based on that model, because it's something that they've been talking about for years, they said. And they believe that our services as a team in the medical world are going to be driven back to the home, away from the really expensive medical centers and those things. And so now it's a matter of building practices that work in the home, where you can deliver proper services to the home to people who need it. And then a lot of it is recognizing, as an example, when you talk about our particular case study, how we do things, we're in a situation where people are dealing with substances, and let's face it, they're in home. If they want to go get substances and use them, they can. We don't have them locked up in a treatment center where they can't get easy access to substances. They can go get them. They can walk down the street and get them. And so what's been really interesting in our model is that we found that most of our clients, if they do have a little adverse event, they self-report almost immediately. It's really funny, but they do. They self-report. They call their case manager and say, I went and drank, or whatever their thing might be, which we found very interesting. But even if they don't self-report, as soon as they miss a meeting, we know. If they miss a meeting and it didn't have a reason to miss it, we know. And then we approach it as if we've had an adverse event, and then we go forward. What we found, In the over a year we've been treating people, we have had 0 instances of people going to an emergency department, not one time. We've had some severe adverse events, though. I'm not going to lie to you guys. We had an overdose, but we figured it out because an appointment was missed. There was no contact. We didn't get hold of the emergency contact, and we asked for a drive-by from a police officer to do a wellness check. And we were able to get that person to detox without an emergency room visit. And that shows that the model works. We can treat people and deal with people in their environment, and we can recognize when there's issues and problems, and then we can address those with our team way quicker.
So I have a kind of you might have a comment on that. I want a question about the other side of the coin, because when we're redesigning care, there are 2 sides that we have to redesign: the patient side and the provider side, or the administrative side. Yeah. What's been your experience? My experience when I'm designing, I've helped do an IOP, a virtual IOP. I've done a lot of group care and individual care systems. What's your experience with the providers? Is there a spectrum of adoption? There are issues there that we need to be paying attention to as we redesign care. Is there resistance?
Absolutely. So I think providers are increasingly not wanting to travel to work. They want to work from home. So we have that late majority coming in. So now the question is not a matter, it used to be a matter of job satisfaction, proving that, telehealth is just as satisfying from the patient side of things and also the doctor side of things. But Steve, you brought up something interesting that I want to build on, which is the idea that, our outcomes measured in lower rates of readmission, because I think that is definitely a big area to focus on. But also, as we identify and give access to people, we may actually push them to go to the emergency room, which might be a good thing, right? So what I'm getting at is that the data used to be all about satisfaction. Now everybody's satisfied with experience. Now, what are we going to do about redesigning how we interpret the data? And what I'd say is that we need to look at outcomes. So we need to redesign it, the data analytics, to say, telehealth versus in person, like what are the outcomes showing us? Because we all can say, everything, makes sense, but unless we see data, and I'm one of the biggest proponents of telehealth from more than a decade, and I've always been pushing, but now that everybody's on board, we need to actually look what works, what doesn't work, inpatient versus outpatient. Some people have strong inclinations to do telehealth outpatient only, and they say, inpatient's too complicated. My personal experience is inpatient works really well, and in some cases better than outpatient. But that's just my experience. So now we need to look at the data. And I think that's a big part of the redesign.
Yeah, I'll say just quickly, I think it is too. I think the key factor personally is engagement. And I think however you can get a client to engage, you're going to see success. And that's what we're seeing. Clients who engage, and if that's via telehealth, or if it requires us to do maybe some more in-person visits, which we're very flexible, by the way, in our programming around a patient. And so we'll give them more in person if they need it with whatever services. Engagement is what we're looking for. Clients who engage, and we've seen it. Now, data sampling is too small, okay? But what we've seen so far is very positive with those that engage.
How do you get people to engage?
Sometimes it's really hard. Sometimes it's really easy, and sometimes it's really hard. It's the case managers. It's the bane of their existence.
So, Dr. Harrison, do you want to weigh in on that as well?
Yeah, I can weigh in on engagement and data. Ed, thanks for saying it. We have this concept at Eleanor that's moving beyond evidence-based care to data-driven care. And as substance use disorders are chronic medical conditions that can be relapsing and remitting, at times it is appropriate for an ED visit. At times it is appropriate for a residential visit. At times it's appropriate for an IOP or PHP. Where the current system is lacking is that those are thought to be the default, and that is where people understand to go. And so whereas Aspire, Eleanor, Orbit in the correctional system can divert unnecessary use of those higher levels of care, we can't start to believe that those levels of care will never be necessary. because that would be the same as believing nobody with diabetes would ever get ketoacidosis and need the ICU. It is not reasonable in terms of the natural history of a severe substance use disorder. So as we're trying to figure out what is the appropriate setting and how do we divert people from unnecessary higher levels of care, using telehealth, using home-based care, using multimodal care, data is what will tell us that. And so at Eleanor, we've built our proprietary technology from the beginning so that the workflow is creating that data in the background. And I think that's been part of the difficulty for proving outcomes in behavioral health because we don't have the technology. We're asking our clinicians to also collect data while they're trying to practice care. And so technology has to collect the data in the background just as part of the routine workflow. And then you use that data to aggregate to the population level, move to, artificial intelligence, machine learning, prescriptive clinical decision support, looking at that kind of quadruple aim of outcomes. And then Steve, I agree with you wholeheartedly. Engagement is the name of the game. And part of the strategy that we've enacted at Eleanor Health for engagement is that the current substance use disorder treatment system really focuses on people who are in action and maintenance stages of change. We know the majority of people who need substance use disorder treatment don't get it, and a good bunch of them are in pre-contemplation, contemplation. And so how do we also engage with a harm reduction model incorporated in treatment? Those folks who are pre-contemplation, contemplation, engage them around what's important to them, invest in that relationship and engagement to move along the stages of change to action and maintenance. And so just highlighting and reinforcing that conversation Steve and Ed were having.
I think it's,
Go ahead. I just want to ask Brian if you wanted to weigh in on that.
Yeah, this panel is just so exciting because those are fantastic examples of the data. You're talking about engagement data. Dr. Harris is seconding that. You're talking about, I think we're at the tip of the iceberg for telehealth data. And I also think that because of the pandemic, we're at a point where there's a load of new great papers coming out, of great insights, of great knowledge that did not exist before. I am involved with academia and an active researcher, but encourage those that are considering, developing more behavioral health programs, read some papers. There's some great information out there, and encourage those who are, the Steves and Edwards and Najingas of the world to publish. Get your data out there, get your information out there, because it just helps everyone. It helps the larger kind of boats float with the behavioral health information, and in this situation that we're in, which really is a global crisis. But go ahead. That's all I just want to say. At tip of the iceberg, and let's keep exploring.
Yeah, I agree with you, Brian, that there's a lot of great information out there. People are starting to it's starting to percolate and sort of we're talking to each other about it. One of the things that we're bringing up here is primary care versus specialty care. So as a psychiatrist, with Orbit Health, we provide specialty care, psychiatry to community mental health and correctional. But there are a lot of other companies coming out, seeing opportunity, seeing the potential to be profitable, and they're taking the low-hanging fruit. So they're saying, we will only see patients with mild depression or anxiety. And then, companies like mine are left to deal with the really challenging cases. So one of the things is there going to be a pay differential? Because you advertise, $50 a session. Well, what is that though? Is that like a life coach? Like what is that? And the market, as we've been talking about, the market is pushing hard, and we don't have enough providers, right? Like licensed psychiatrists, psychologists. It used to be psychiatry was the one that was the biggest shortage, but with the mental health crisis post-pandemic, now psychologists and social workers are becoming in high demand as well. So then the question is, when we redesign healthcare, is it going to be for specialty care, or is it going to be for primary care?
And how much of this can we ask the patient to help themselves in a capitated environment? Especially, we need to be helping people help themselves. So the people in the room here and probably the people online are what fit in the category of the worried well, right? We're self-actuated. We can help ourselves for the most part. So if we had somebody guiding us to care, do we need a lot of 1-hour sessions for that care? Or could we be guided to do some of this help on our own with a little prompting and coaching and assistance along the way? I mean, from a clinician, of course, but more guided care instead of our old model, right? We could probably do this more efficiently. I will say though, as the clinician or another clinician on the panel, I prefer the model that we have now. I mean, it's slow. It's easier.
What model?
The 1 hour, 45 minute, I can kind of take my time. I'm not rushed to kind of get to the bottom line. And so I think there's a natural pushback from this is like, unless there's an economic drive from the providers, there's a different thought process and maybe some pushback. They got to think about, how do we care for more people more efficiently instead of just making it easy for me as a provider. What do you guys think of that?
Yeah, it brings up a lot of great points. Where we are seeing a lot of innovation with who interacts with that patient first. Is it, a coach, then a LCSW, then an MD, then a counselor, then an MD,
or is it
AI? And I think we're seeing all of the above right now. And I think that's what's like, it's fascinating to watch all of this. But yeah, go ahead.
No, what's kind of interesting, we start all of our patients, their first visit after they meet their case manager is with their psychiatrist. And we actually work it top down, and then they meet their therapist. And then they meet their nurse, and then they meet their family therapist. And then they finally meet their peer support. We actually introduce that person very last. And they work most often to begin with their therapist in that first month. They'll see the psychiatrist once or twice, sometimes twice, unless more is needed. But what's also interesting is we found is patients stabilize and they really need the team less and less, but we have continued maintenance. It seems to be so far the one person that they continue to want to work with is the individual therapist. Seems to be the lasting person that because it's, as they break down over a period of time with that therapist, they start working on more things. And so that becomes the important part of the team to them. That's what we've seen. Not in every case. But
why top down though? Why not bottom up? I think, you can make an argument either way. Like, do you cast a wide net and say, well, you need a psychiatrist to diagnose something that could be a medical cause of a mental health condition, or you might have a psychiatrist seeing a lot of people they don't need to see, and which may be inefficient. But then if you start bottom up, then you have somebody who may not be trained in medical matters that might incorrectly identify, medical issue as a mental health issue. So do you cast a wide net, what you do, Steve, or do you go bottom up and say, well, you're going to count on your therapist to kick it to the person who is going to be able to diagnose a medical condition?
Yeah, our thought there is to get them with the highest level professionals first to build the proper treatment plan. And then other people within the team can implement the treatment plan and then report back to the psychiatrist. That's our thought, because again, if it is a medical condition, if there's medications needed, those sort of things, we want to hit that right up front.
So that seems like a safer way to go. But I do believe that in the marketplace is now a lot of people, like maybe suicidal people, maybe people with massive, head like traumas or dementias or medical conditions are being seen by like a life coach, like, and that, whoa, I can't deal with this. We got to, yeah. So,
it goes up,
like
up,
the market
up,
is
yep.
saying we'll provide everybody with $50, a visit, but then, whoa, this person actually needs like real care.
And the problem that I see it's a good point, is that when's the last time you had a life coach who said he couldn't deal with it? They all think they can deal with it.
Oh, great.
That's
point.
scary.
That is
I
scary.
mean,
No,
nothing against
scary.
life coaches.
No,
I think
nothing against them, because we use them. They're great.
They're needed.
They're needed, and
Right, yeah.
they
They're
do a
part
great
of
job.
the equation.
They serve an important role in
So-
the equation. But
A question is, so there are entrepreneurs out there doing care model redesign now.
Yeah.
And are there concerns about over designing it in such a way that it's taking out the expertise, the human touch? There's I don't want to name names on apps and things like that, but there's some that seem to be more pill mill approach to anxiety or other disorders. Is there a point where we stop designing and say this is enough?
I hope not. I mean, I will tell you guys, I think we learned more in treating our first 8 clients than we learned in the 3 years previous. And I'm saying that in the first month of treating our first 8 clients.
Yeah.
I'm serious. When you're dealing with actual people and their actual issues and their actual problems, and every person's different, right? And every patient is different and brings something new to the table. And so we do so much self-designing of the program around every single individual client. It's crazy. I mean, we have clients who simply will not use peer support or life coaches. They don't need them because, I have a friend I talked to who's been through the same thing or something similar to me. I do not want that. I'm super busy, and he's a working professional. He's a busy guy, but he has really latched onto the therapy, and the family therapy has saved his family. He'll tell you that.
So one size doesn't fit all.
For nobody.
That's a great point.
For nobody. One size does not fit all for anybody. Something interesting, and I'd like your take on this, Ed. Our psychiatrists that we work with, like as an example, for medication-assisted treatment, they never put a patient on medication-assisted treatment. They talk a patient through to make sure they are fully on board with that they want to do that they want to be engaged in that. And I like that approach because maybe some people just don't want to do it. They want to try to get off everything. They want to go full abstinence, whatever that is. If that's their decision, we'll support that. But I like the engagement, not versus a psychiatrist saying you're going to do this. We try to be an engaged model where we let the client to a certain point dictate how we treat them, but then we really engage them.
Yeah, I mean, that rings true for me as well. The medicine used to be a very patriarchal model where the doctor, you go and you just do what the doctor tells you. And now it's like driven by the patient oftentimes, where they go to the doctor with a specific demand sometimes of a medication. And so maybe the truth is somewhere in between. And I think we got to keep redesigning healthcare because it's broken right now. We know it. Everybody knows that it's broken. And so we redesign it. I mean, I think take home points for the audience here. There are all kinds of ways we can redesign. So the definition of telehealth, what does it mean? What does it incorporate? And I think that in the early days, we were all thinking, well, hopefully one day telemedicine won't be a word that's used because it's just part of medicine. So definitions, consent rules, prescribing controlled substances, liability, malpractice is a huge area that is completely behind the ball on this. Once the suicides start coming in, with and I don't want to pick on life coaches, but like if you're a life coach and you have a suicide, what does that mean? Are you practicing outside of the scope of your license? Or you don't have a license. So like malpractice is an issue. And then the government and the rules and regulations are way far behind. And one of the things that I'll just say one last thing on this. One of the things that has been really beneficial to Orbit Health as a company. One of the things that's negative about the pandemic is we got a lot of competition now. Okay, so there are lots of telepsychiatry companies out there, but one of the benefits of this is that all the rules and regulations that were arbitrary seem to have been relaxed. Ryan-Haight Act, the HIPAA rules, and that just shows kind of how arbitrary some of them were because right now things are going pretty good. So that's part of the redesign.
Yeah. So
great point.
A lot of people might be listening, wondering, how do we go about doing this? Because maybe you're not, expert in redesign or expert in telehealth. I know a lot of us want change, don't know quite how to get there. I know I do a lot of consulting in the space. I know Brian does a lot of consulting in the space, and I'd like to get Dr. Harrison's take in a second here too. But I think it's a good point to start with what's painful, of course, and you can iterate towards that change. But we bring in a lot of assumptions about how things could be or should be. I think also in telehealth, a lot of people don't know what they don't know. They don't know what's possible. So talking to a telehealth consultant could really help that. There's a lot of grant-funded consultants out there as well to help you open your mind to what is possible. Talk to a couple of them because there's probably a difference among what their experiences are. And different talent levels. Dr. Harrison, did you want to weigh in on some of the conversation?
Yeah, I'll weigh in on a few points that were made. I think, Jay, you started out by saying we have to figure out how to see more patients more efficiently. And I want to push on that a bit and say we need to figure out how to see more patients more effectively, with the marker of success there not being a productivity number of patients we fit in, but rather a clinical outcomes number of patients who got better. And I think that does change the way that you start to design services. And I heard the conversation with Ed and Steve kind of asking this bottoms up, top down, like who do you have see the person first? And before jumping that, I think Ed, it was you that said, when we're designing, do we design for primary care or do we design for the specialist? And I think the answer has to be yes. Like, I think we have to bring it all together, and kind of operationally at Eleanor, our medical team is multi-specialty, even though we're all practicing addiction medicine. And then our psychiatry team is practicing general and addiction psychiatry. We're multi-specialty with family practice docs, internal medicine, obstetricians, gynecologists, ICU, palliative care, NPs. And so it kind of allows for that internal ability to save the specialist for the more complex cases, because we're training the more available resource, which is the non-psychiatric medical resources, kind of to practice what we call primary behavioral health. And then in terms of top down, bottoms up, our harm reduction approach is that the first visit is actually driven by the need that that community member tells us that they have. So since we're practicing harm reduction, sometimes the front door is straight to MAT, right? They're like, I need help with heroin, I'm in withdrawal. That's straight to the medical team for MAT, but it could be, I'm stressed out at work, and that could be to a peer, or it could be my medications for depression are not working, and that would be to primary behavioral health, or depending on complexity, straight to psychiatry, or I just got out of the hospital and I got a new diagnosis of congestive heart failure and I don't know what it means. And that first visit is to the nurse care manager. So I think being able to be flexible when we're designing to center the voice of the person who's receiving the care, which is difficult, right? From a productivity and design and standardization of process perspective, but I think worth it from an outcomes perspective. And so I think and then the last thing you said, we have to design for the payer and the provider. I don't remember if it was Ed or Steve, combination of, I'm sorry, you said the patient and the provider added in the payer. I think the government and legislators also, like, there are a lot of barriers for telehealth. Ed, you said it, that were totally arbitrary, that went away, and we are actually getting better outcomes, right, with those regulations away. And so how do we present the data to all four of those stakeholder groups to free us, so that exactly what Ed said, healthcare can just be healthcare. It doesn't have to be telehealth care, in-person care, home-based care. It can just be healthcare based on what the person you're caring for needs.
I'll just add on to that real quick. Centering around the voice, that community comment, Eleanor is, I'm not paid by Eleanor, but to see the growth that they've had, and that, hear Dr. Harris, talk in that way, and I look to some of the other organizations or regions or systems, people that I've worked with that have had success with kind of telebehavioral health, they have kind of figured out how to listen and hear that voice, and really razor in on that need. A lot of the work I've done is in the Appalachia region, and it's a different voice in a different region. And I've done some pro bono stuff internationally, and we'll be doing some stuff in the future. And the voices are very different. Sometimes they speak entirely different languages. They're dealing with entirely different problems. So I think that, for those out there, I think that that's a key takeaway that I think really can resonate when you take it back to your organizations, is really try to listen to that voice that has the need, and not let somebody else dictate that.
Yeah, I'd like to add to that and say that you have to pay attention to where the population is going. So with Orbit Health, we deal with correctional populations, but now with people being sort of more keen to not have people incarcerated for years and years and years. These people are going to transition to parole outpatient treatment clinics, and they're going to try to transition. So you got to capture that. And then we also, my company also provides care for youth. And what we're seeing is that there's an increased issues regarding, suicide. There's youth suicide. Transgender issues are enormous right now. There's a clinic that I serve where like 60% of the children, it's for emotionally, it's for children that have emotional and mental health problems, and they need residential treatment. And like 60% of them are identify as transgender. And so we don't even have a really great knowledge as healthcare providers overall. I'm saying in our country about these issues. So like it or not, our population is changing, and millennials have maybe unique issues that other generations don't have, and then the generations that come after that, and how society is going. So paying attention to all of these things is really important in the redesign.
I agree. We've seen some interesting things. I mean, a patient who came in last week, a young lady who had never ever had a drinking. She had never actually drank alcohol before the pandemic, and was bored and started drinking, and like became an alcoholic. And came to us and said, "I don't know how to stop." And
So yeah, we need to challenge our assumptions,
yeah,
right?
yeah, you're right. We do. I mean, like you say, the population base is changing, and society norms are changing, and adjusting to that is critical. I think companies in general from now on are going to have to be more flexible and more fluid and more able to change quickly as things change around us. And I wanted to make one comment back to your point, Ed, when you were talking about regulation and that, and dealing with states. What I found so interesting is that we started, and we have offices in several states, but we license multiple providers in multiple states that work for us. And so that as we grow, that they can help us with expansion and retraction and stuff. And it was the one great thing in the pandemic is we get people licensed almost immediately wherever we went. And New Hampshire is an example, because we have an active operation in New Hampshire, decided recently, like, okay, no more emergency license. In fact, those all expired, and now get licensed. And we were like, wait, why? You were able to get people licensed and working within like 5 days. And so we ran one of our clinicians through the licensing, and it took, actually, it's not even 3 yet, it's 4 months in. It's still not back. And they were licensed in New Hampshire through an emergency license. They're fully credentialed. It's a psychiatrist.
Yeah.
It's a board certified psychiatrist. It's like, wait, why are you putting us through this? It makes no sense. We've got to get with these states and these federal organizations, say the way, when you made it easier, that was the right way, people.
Oh, yeah. One quick comment. I know Florida recently passed some legislation that if you do not have a brick and mortar location in Florida, you can apply for this special kind of telemedicine license. And it's a faster, easier process. So that's
Smart.
one innovation I think that, will spark tons of growth, tons of kind of unmet needs maybe addressed, but
Yeah, you know what?
Like the panel's thoughts on that one.
It'll help.
So I would say, I've had experience. I have experience getting a Texas telemedicine license. So, it took like 2 years to get it. And I can't believe, like, people talk about Texas as this great, unbureaucratic place, but the medical board, pretty
different story.
Yeah,
I know
different story.
So
go ahead.
Oh,
yeah, I just want to quickly say my challenge with the telemedicine license was, we have business. So Orbit Health has business in Texas, and we have nurse practitioners. And then I went to supervise them, and then I was told, well, with the telemedicine license, I'm not allowed to supervise nurse practitioners.
Right.
And I'm like, what? That is the most random, arbitrary thing. So when you're looking at telemedicine licenses, you got to look at the fine details and say, what does it allow you to do?
What the rules? Yeah. I think what I like about each of the companies, representatives, we've not just taken, it's easy to pound on the government systems that are not working well. And of course, there's a place to say that. But I think we've done well to pivot around them and grow and innovate in regardless of them. So I think that's important. In our last few minutes, I guess I would like to have the panel talk a little bit about just that process of redesigning a little bit, because if you're new to this could be rather daunting. I mean, we do this for a living. This is normal for us. I advocate a lot of experimentation, a lot of data collection instead of blowing the wad on one big thrust. I learned that iterating is a key to success in so many areas. What would your advice be to people that are wanting to do care model redesign going forward?
I think you have to be ultimately flexible. I think you have to be willing to go where it takes you. And I think that's difficult for a lot of organizations. But I think if you're not willing to be flexible, I just don't think you're going to survive. I do. I think you have to be ultimately flexible. And I'll tell you guys, that's with payers. We've been in negotiations with every major payer in the country, and we're in contract with some of them. And we're working with the rest of them, but helping get their systems up to speed. I mean, we had one payer who told us how much they hate out-of-network billing, especially in the behavioral health industry. They told us 20 times how much they hate it. And then they said, well, it's been really hard to get an in-network contract, so why don't you just start billing us out-of-network? They said that. And we were like, wait, you've told us for a year how much you hate that system. Yeah, we really do. Well, then let's not do it. That's a good point. And they gave us an in-network contract and we got it done and we're working great with them and they're great. But it's just like, it's having the flexibility. And I think in some things like with that, you have to stand your ground.
Well, and that you actually went and advocated for a change.
We did.
So instead of just taking the rules as is, so part of that redesign might be advocating.
And it was a lot of advocating for a change, and it was advocating for them to understand our model and how we deliver services, because we wanted this to be a value-based proposition, not just for the insurance companies, but for the clients. No balance billing, none of that. Yeah. Not sticking these people with $100,000 bill at the end of their services. So they, it may as well be $1 billion. You give somebody in that situation, $100,000 bill, just say you owe me $5 billion. It's the same number. And so we didn't want to be part of that system. And so we had to work closely with the payers to make sure we had a system in place that we could deliver good services. We could be a profitable company, but we could deliver services that work for everybody. It works for us, it works for our patients, and it works for the insurance companies. And you have to be incredibly flexible to do that. And it took a lot of negotiation. As in some of our contracts, we negotiated weekly for 6, 7, 8, 9, 10 months to get it done, and then you get it done. But it's an effort to work in those systems and help them, bend a little bit towards our way of doing business in this kind of modern world.
How about you, Edward?
So what I've learned, and Orbit Health's been around for almost 7 years, and what I've learned is also to be flexible. We started out with the focus on correctional, and then we saw opportunity with community mental health. And we're seeing opportunities now. The smart companies are able to pivot. I mean, that's just a business 101 lesson. You have to pivot. And there are some really exciting technologies out there and treatments like ketamine treatment. You have TMS and some really unique modalities that I think smart companies are going to look at. Where is the demand the greatest, and where is the compensation? And as far as the payers, where are they right now? And so I'll leave it at, it's a balance between making sure that you do appropriately, clinically serve the patient appropriately, do it in an efficient way with consideration for rules and regulations that are evolving within a malpractice climate that is ever changing and unpredictable. So if you can kind of thread that needle, which is really hard to do, then I think that you're going to be in good position. And then never forget, you got to work around consent, controlled substance, regular prescribing practices, licensing, and if you can do all of that, then tell me how to do that.
Well, I think with anything, it's developing a procedure and a policy and routines, habits that become muscle memory and easier, and then you layer that with another one, layer that with another one. It can be overwhelming to start, for sure. Dr. Harrison, do you want to weigh in on any advice on people trying to do care model redesign as a start?
Yeah, I can be quick. So agree, flexibility is key. Tenacity is key. Creativity is key. Recognizing that even though we're often positioned diametrically opposed to our regulators and legislators and payer providers, that we really want to approach it as a partner to help them resolve their pain points. Like he said, we hate contracting out of network. Okay, well, let us help you figure out how not to do that, right? And so I think it really, the last thing I'll say is around risk. There is unnecessary risk built into the system, which is really based on stigma and kind of just like the adoption curve of innovation and technology. So I think you have to be able to be very aware of that risk and proactively prepared to manage that risk without letting that risk stifle your creativity. So you have to be willing to push the envelope and bend it almost to the point of breaking.
Brian, did you have any final thoughts?
Just one question for the panel members that's kind of related to the last answer. Have you seen much on the virtual first movement or trend, and what are your thoughts on it? Because we know that a lot of payers are now offering a virtual first kind of health plan option. Are any of the panel members kind of, what are your thoughts? Are you taking any action on that?
You define virtual first.
So it's something that I saw that the Dime Society put out, and it looks to be kind of, and I also know the ATA's put a lot of stuff out on it. But initially you had some payers starting in around 2020 experimenting with a virtual first plan, which encourages enrollees and patients to kind of seek virtual care first. And that's almost like a triaging kind of level and kind of pops you into a process. I've also heard it described as almost replacing the high deductible health plan. And so, yeah, that's, and we know that pretty much every major payer is offering a virtual first health plan starting in 2022.
We need to wrap up quickly. Ed, or sorry, Steve, you want to?
I don't have a lot of familiarity with the virtual first, and so it's kind of funny. It would fit our model great. So works for
There
me.
you go.
So,
Check it out.
Dr. Harrison?
I think virtual first has a lot of possibility. I think we have to make sure we don't leave behind those communities where we have disparities in access to virtual medicine, and make sure, which we tend to do as humans, which is like, that's the cure, to recognize that it can be virtual first, but not virtual only. Those are the two risks I see in it, but I'm bullish on virtual first.
Yeah, spectrum of options for the spectrum of needs.
Yeah, with health equity in mind.
Thank you guys. We're at our time. Thank you for having being on the panel and contributing your wisdom to us. Thank you.
Thank you.